All right, welcome everyone. Thank you on behalf of HR.com for joining us for this webcast, Brokers and Employers' Role in Fighting the Obesity Epidemic. This has been sponsored by Diabetes Leadership Council. This is approved for HRCI and SHRM credit, one of each. Please be sure to attend the complete webcast in order to receive your credits. You'll receive an email from HR.com within 2 business days that will include your certification information. So during today's webcast, we'll have a couple of poll questions as well. The chat is open for engagement. With the amount of presenters on, if you have questions for anyone, we ask that you use the Q&A in your webinar controls so it does not get buried in the chat. So again, any questions for anyone, we ask that you put that in the Q&A in your webinar controls. All right, that is all the logistics on my end. It is now my absolute pleasure to turn it over to you, George Huntley.
Thank you, Rhonda. Good afternoon, everybody. My name is George Huntley. I am the CEO of the Diabetes Leadership Council. I am also a patient living with type 1 diabetes for 40 years. I'm a past national chair of the American Diabetes Association. In my other day job, I'm the chief financial officer of a professional services firm based in Indianapolis, Indiana. And in that role, I have been the plan administrator of a self-insured health plan for over 25 years. So I've been in that payor benefit role, and I still currently have that responsibility as well. So I, again, appreciate everybody being with us today, and hopefully you have we should have a good dialogue. I do want to start with a disclosure. This program is sponsored by Eli Lilly and Company, and a couple of our presenters are receive an honorarium from them, and are also part of the provide expertise to Lilly as part of what they do in their professional roles. The Diabetes Leadership Council, a very quick comment on us. We are an organization. Everybody on our board is a former leader of a national diabetes organization. We are patients, parents, and allies of people with diabetes. We're a policy shop educating legislators and advocates. Through this program, we're educating employers on issues important to the health of people with diabetes. Today's program deals with the primary driver of type 2 diabetes, which is obesity. So we're going to talk about the state of obesity in the United States. We're going to get into the fact that it's a complex chronic disease and talk to some medical experts about that. And we're going to talk about the stigma and the bias that comes along with obesity and overweight, and what can happen in the workplace, even specifically on that. So we've got a lot to cover today. And I'm going to start us off with this and invite Dr. Allison Sexton Ward to please join me here. And Dr. Ward is a research scientist at the University of Southern California Schaefer Center for Health Policy and Economics. She is an economist with extensive experience on healthcare policy and pharmaceuticals. She is the co-author on a paper released this spring called Benefits of Medicare Coverage for Weight Loss Drugs, which we're going to discuss a bit today in today's program. And again, welcome, Dr. Ward. I really appreciate you joining us. I think let's just get into it. We're losing this fight against obesity. You and your colleagues at the Schaefer Center have studied the obesity issue. Where are we heading?
Well, George, things don't look that great. And despite decades of public health efforts to fight obesity, we can't seem to reverse the trends. And in fact, we're outpacing all of our previous projections. So as this graph shows, we are average BMI for American adults is right about 30, which is that obesity threshold. So it's also projected to continue to grow into the coming decades.
Yeah, that is very depressing. About half of America is dealing with obesity. So I mentioned we know it's a public health crisis. I know you agree with that. Share a little bit more on the scope of this problem.
Yeah, I think a lot of us have heard about these rising obesity rates, but maybe the more salient thing is to talk about the dire health consequences associated with diabetes. So, for example, obesity is second only to cigarette smoking in terms of preventable deaths in the US, and nearly 20% of deaths for African American and Caucasian Americans between 40 and 85 is associated with diabetes. So again, back to that first slide, we're failing to reverse the trends or slow the trends. And a lot of this comes down to access and uptake of available treatment. So as we get new treatments that are actually effective, we still have many insurance plans not covering them, and very few people having access to treatment. So we as economists like to think about this, these public health issues in terms of their total burden to society. And so really it's like multifold, but really it comes into obesity is associated with increased mortality, right? So many years of life lost. There's a great article in JAMA, if people are interested, that estimates this life loss in different subpopulations. But as the slide suggests, you know, in certain populations, it's as much as 20 years of life. And a lot of this is driven by the increased comorbidities or the health conditions that are associated with being overweight and obese. And so first and foremost, there's a lot of disability and pain associated with being overweight, but really there's all of these chronic diseases that include diabetes, heart disease, hypertension, cancer, and many others. And as economists, we then look at how that impacts society. How much are we paying for all of the excess comorbid conditions that impact the obese population? And so there's estimates that the annual costs in the US are in excess of $260 billion a year for these medical costs associated with obesity, or that the average American is spending 50% more annually in medical costs. The average obese American has 50% higher costs than their non-obese counterparts, which is pretty stunning. I think something that's certainly important to think about, but less well measured, is then the productivity costs. So it's hard to find data sets to measure this, but studies that have done that have seen really significant impacts on both presenteeism. So that's how productive you are on the job when you're there. So your productivity goes down with obesity, but also the days missed at work. And so that can have a big impact on the working population.
Yeah, and I to underscore that as a CFO, if you've got somebody who is missing 3 days on average per year, an extra 3 days on a 50-week period because they're going to be on vacation, that's an extra 1% of pay cost, of payroll cost. And as a finance guy, if you take anybody and you add 1% to your salary cost, that's a lot. That adds up in corporate America. That's big money. And that 50% higher annual medical costs, that's a big number that we aren't really paying attention to. So I appreciate you highlighting that. You know, we know our audience today are HR benefit professionals, right? So what's the trajectory in working age Americans?
Yeah, I think that's the other part of the trends that people don't recognize all the time. But what's alarming is that obesity is increasing within younger populations. So here we have nationally representative survey data that's looking at obesity rates, and we see that they're really highest. That average obesity is really highest in the working age population, 25 to 65. And data shows that it's natural to start to lose weight once you hit retirement age. So this is really a public health concern for the working age population.
Yeah, and clearly employers, you know, this is the subcontract cohort that we're dealing with. These are our employees that are at this, and most of us, I think, understand it, but you don't until you see it in writing or see it on the screen like that. It really hits us. Now we know that diabetes hits minority populations, disproportionately. It starts with obesity, doesn't it?
Absolutely. I think what's stunning is when you look at again, representative data, nationally representative data suggests that, you know, obesity, which is BMI of 30 or greater, the rate of obesity among Black Americans is 60%. Among Hispanic Americans, it's 50%, and it's 40% among white Americans. And so that difference is pretty stunning. And what this figure also shows us is the biggest difference is driven in those higher BMI categories. So off to the right there on the figure. So the 30 to 34 is not that different, but as we get into the severe obesity and the morbid obesity, that's where we really see these racial and ethnic disparities start to come into play. And that's also where the biggest health burden is associated with being obese.
And if you think about the employers watching this, you know the demographics of your employee base. If you happen to be in the South, if you happen to be in which we call the diabetes belt, you're going to see this in your population, and it's one of those things. So now you have sufficiently depressed us all. So I know that you and your colleagues at the Schaefer Center released a study on the benefits of Medicare coverage for weight loss drugs. Share with us a little bit of hope. If we actually treated this disease, where might it go from the numbers that you've got now?
Sure. We used our proprietary microsimulation model to look at some scenarios where Medicare covered obesity drugs. So right now there's a moratorium preventing them from covering weight loss drugs. But if that policy shifted today, what would happen 10 and 20 years into the future? And that's those red bars there. So what this figure is showing us is the decreases in these chronic comorbid conditions. There's also some belief that private insurance will follow suit with Medicare. And as you saw, the obese population is really highest within this working age population, likely covered by private insurance. Also, these folks don't already have all these chronic conditions. So we see that if Medicare and private insurance team up together, you can see some real reductions in some of these comorbid conditions. And so looking at diabetes, that reduction in prevalence, that 17.3% reduction in the prevalence of diabetes in 20 years, that's really the same as 23 million fewer people in 20 years with diabetes. Or since this is a chronic condition, it's really 45 million people years. So that's years lived with diabetes that would be reduced if we came together and covered these drugs. I think the other thing that's important to note, as you mentioned, the disparities in the obesity rates, we know that some of these socioeconomic determinants of health also impact how likely you are to respond to treatment. And that as we simplify treatment, the disparities also decrease. So this 17.3% is really going to be skewed towards larger reductions in some of these subpopulations that are most impacted right now.
And I think this is a telling graph. And again, as a diabetes organization, the opportunity to reduce the incidence of diabetes by 17% is stunning, and your math is undoubtedly accurate because that's what you do. So I'm not going to question your math. But what is super exciting about it, I mean, and you look about the opportunity for us to get ahead of the curve, but the employer has to play a role in this. Employers cover half of America, and the working age folks, it's more than half. If employers don't play this role, we don't get this kind of a bang, because it's staying healthy for the longer period of time that is so important, and giving the people the opportunity to do that. So this is really hopefully important and impressionable information that the folks are watching can see. So I really thank you for sharing this data with us and all of your expertise, and setting the stage for the next panel, which will be the medical side. And we're going to talk a little bit about what this all means. But thank you so very, very much for joining us today.
Absolutely. Thank you.
Thanks. Now I'm going to move to a poll question, and hopefully that's going to pop up on your screen. And the question that we're asking here, and while it's coming up, is, do you know the percentage of your employees or the number of your employees with obesity? And it's funny, in diabetes, we're all tracking that. What gets measured gets managed. And I'm a big believer, as a finance guy, as an operations guy, what gets measured gets managed. And if we are tracking diabetes, then you're going to be tracking what happens with it and the outcomes, et cetera. But in obesity, we've had this conversation with a couple of groups. We're finding that people aren't tracking obesity. And some of it gets back to doctors aren't diagnosing it, or aren't calling it that. And we're going to talk about that with the medical group, medical panel in a second. But I'm just wondering if this is something even on the audience's radar at this point in time in 2023. So I appreciate if you click the button and yes, no, some of you may not be sure. And hopefully that will get pushed out. I'm not sure what people are seeing on their screen, but I will say the answers are 8% said yes, 75% said no, which is not surprising, and 17% weren't sure. So, only 8% said yes, 75% no, and 17% were not sure. And that's what we're seeing in most of these. Hopefully after this, we start paying attention to, again, what gets measured gets managed. Let's start measuring this and paying attention to it. So now we're going to move to a medical panel, and it's my great pleasure to introduce Drs. Miller and Dr. Campos to join us here. Dr. Eden Miller is an osteopathic board-certified family practitioner. She is certified in obesity management, and she is the CEO of Diabetes and Obesity Care, LLC in beautiful Bend, Oregon. Welcome, Dr. Miller. Thank you for joining us today. And Dr. Carlos Campos is a clinical adjunct professor for the Department of Family Medicine at the University of Texas Health Science Center, and has been practicing primary care medicine in New Braunfels, Texas since 1984. Both of these learned medical professionals have a list that I could have read for another half hour of all the things they've done in their career, what they've published, and the things that they have done. Just suffice it to say, these guys are experts on this topic in diabetes and obesity. So again, thank you so much for being with us.
Thank you.
So as the slide says, obesity is a disease. And it's a relatively new designation within the last decade or so. Share with us why that designation is so important and some of the drivers that make this such a challenging thing to address. Dr. Campos, if you just kick us off.
Absolutely, George. Thank you again for having us talk about, I think, this very important topic here, because, I think often not only the medical societies as well as the employer societies, we often don't think of obesity as a disease like we would say consider diabetes or hypertension or high cholesterol or heart disease. And when we see it as a disease, then we look at it differently. And you'll be surprised how many clinicians, whether they're doctors or nurse practitioners or PAs, still don't consider obesity as a disease. And when you see it as a disease, the reason it's so important is that we can move from this whole issue of blame to biology. And I think that's, if there's anything that I want the audience to take away from today, is that, number one, this is a disease that we have to look at it just like we treat diabetes or these other conditions we'll talk about. But also that this is, often we think of it as a condition that really it's a lifestyle choice. And I'm thinking that, I'm hoping that at the end of today's webinar, that we can look at it as more as a biology that happens. And it's, as you can see there in the chart, it's more complex than you think. Vastly underrated. There's a lot of multifactorial drivers, not only genetics, but this whole aspect of metabolic adaptation. That means that what we know now in the obesity world is that once a person, this is usually 9 out of 10 people we're talking about, that once they hit their maximum weight gain, George, that their body does everything to defend that. We call it the set point, their maximum weight gain. And so what happens is that the people will lose weight, and we often think of it as the Nike switch. They lose weight and they gain it again because their body's going through a survival mechanism that they think that their maximum weight is their normal weight and they want to go back to that. And so the body adapts to that. It's what we call metabolic adaptation. And that's why, it's the first time you lose weight, the second time it's harder. The body adapts to that. And these are issues that are caused by biology. I often talk about it when I talk to my patients and say, there's really a hormonal conspiracy for you not to lose weight. That's why it's so difficult.
Everything's stacking against us, and but people don't realize it fully, including the patients and probably some employers. Now, we know that diabetes is a continuum of blood sugars, right? But obesity is a continuum of our body weight as you get to the classes, et cetera. So at what point is a person technically diagnosed? And talk to us a little bit about this spectrum.
So it's how do we diagnose obesity? And as you can see, what the model we have is this body mass index, and it's not really the best model. It's what we have now. You know, I think when you talk to researchers, they often think that maybe the waist hip circumference is really the way to go. But right now, we have this body mass index that we do, and what it does, it compares your weight with your height. You know, there's no question, I got bodybuilders in my practice who, you know, have BMIs of more than 30. And they're not obese, but they got a lot of muscle mass. But overall, one of the way we diagnose to have obesity is to have a BMI or body mass index of 30 or higher. Between 25 and 30, we call that overweight. Overall, we're saying that normal weight should be a BMI between 18.5 and 25. But again, you know, once you hit that BMI of 30 or higher, then we consider you to be obese. And then you can see the different classes of obesity, BMIs between 30 and 35. We call that class 1, and then from 35 to 40, class 2, and then anything more than 40, class 3.
Well, and yeah, and you really don't want to go. The harder, what I'm hearing is the further you go here, the harder it is to go left. The further you go to the right, the harder it is to go to the left on here. Right?
Well, you know what? Even if you're able to go left, the question is, how can you maintain being on the left side?
You stay there.
Because remember, once you hit that maximum weight gain, say you're over here with a BMI of 35, again, you know, one of my where I went to med school at Baylor College of Medicine, my alma mater did a study where it said that really obesity is a brain disorder. It's like your brain recognizes this maximum weight gain as a normal weight. Now, we all know people who have lost 50 pounds 10 years ago and are able to keep it off. We say, congratulations, let me applaud you for that. But that's usually 1 in 10. I usually tell patients, you have a genetic proclivity for that to happen. But 9 out of 10 people don't. Their brain remembers that maximum weight and does everything it can to try to get back to that weight, that hormonal conspiracy concept.
Great point. So, you know, there's a lot of bad news there. And so, you know, we think about the comorbidities as we think about this. And from the diabetes community, there's a good, strong link to obesity and comorbidities and the complications that come from diabetes. And the really bad health outcomes when people are dying with diabetes, it's the complications. And I looked at this comorbidity list of obesity, it's even worse. You know, diabetes is one of the things that comes from obesity. So Dr. Miller, share with us a little bit about this disturbing slide.
Yeah, it really kind of goes beyond just how you look in a swimsuit and how you move your body. I mean, we're really looking at what we call metastatic obesity-related conditions. And I know that we're really kind of setting this foundation. All of us are sitting here thinking about where we go on the scale, right to left, but we're really serious about this. If we were to impact obesity-related medicine, look at the potential and the hope we have. It's because it is associated with it. It is a foundational type of issue. And by improving the metabolism and the overall health of the individual, we have this trickle-down effect. We know that by central focus on this, we improve the risk of cancer and heart disease and diabetes. We already mentioned about type 2 diabetes. You know, it's 1 in 3 right now that are going to get type 2 diabetes as an adult if we don't impact that. And we don't want the shame of obesity-related intervention to shift into diabetes too, and to shift into these areas. Rather, this is an opportunity for honing on the core problem, right? Honing in on a core problem to have impact of all of these other medical conditions that are on our plate, and we all engage in those and how to deal with the core defect.
Yeah. And so, as you say, you know, there's good news, there's hope if you do get some modest weight loss. So to give us a little bit of, you've given us the bad news, let's swing that back. You know, you don't have to lose 50 pounds in order to get some benefit.
Absolutely. And this is what I like to educate my colleagues on, I think, the most, but it's also very empowering when I have individuals come into my office for weight-related challenges. We are looking at something that greater than or equal to 5% body weight. I never talk pounds. I never say to an individual, 50 pounds, I kind of say, let's look at your current height. Let's look at your current weight. Let's talk about a 5% weight loss. That's considered a good start. In fact, we see these preventative things that happen. In fact, the diabetes prevention program showed that a 7% body weight had a significant impact on preventing the occurrence of type 2 diabetes. But we can start to see immediate impacts on health. And so I talk in the office about being healthy. I talk about being healthy, utilizing your body, the nutrition, the timing in ways that will help facilitate your health, which will end up in weight reduction. Now, 10% is really what we're looking for. A lot of the colleges of diabetes and cardiology say 10% is a goal we need to shoot for, because that's where the meaningful reduction in what we call the comorbidities. Now, 15% is really this new kind of what I call the holy grail. And that is the ADA recommends a 10 to 15% body weight reduction. So imagine an individual struggling with this, having this, and I sit there and I calculate that number for them. That first goal, second goal, and third goal. And I say, do you think you can do this? And they're like, absolutely. I totally can do that. And what you do is you're there with them on that journey and you celebrate all those different milestones that they achieve.
Yeah. And I don't have to get to my high school weight.
Exactly.
I was a little kid in high school anyway. This is very disheartening news. It doesn't take.
You wouldn't look very good like you did in high school. You're a grown man. You want to be that strong individual,
Yeah, but I had those really high white socks that went over the calf back then. But we digress. So that obesity is vastly undertreated. So talk to us a little bit about what those barriers for that treatment.
I think we're already breaking down barriers right now. You've already heard Carlos give you some great nuggets, some great images of that it's a chronic disease and we got to treat it like that. You don't go to your oncologist and they say, if you just would have exercised more, it would have been better. And we're all going to be better for it. There's a lot of reasons why we have the condition of obesity, and it's not just behavior. And that we really don't recognize it even within our profession. And these are the things that we're talking about. We're naming it, right? A job begun is half done. We try to bring it up in the clinic. We do it in such a way to say, hey, would you be interested in talking about what an ideal weight would be? And these individuals don't even receive counseling regarding it. Those are healthcare professionals that are there cheering them on and saying, hey, way to go. Now, when we look at some of the demographics things, which is great to look at what we call our habits, we don't even have individuals being labeled as those issues in our coding as having a diagnosis of obesity. And I'll be honest with you, there's a lot of reasons for that. I sometimes want to move to where Dr. Campos is because his regional medical climate is different. In my area in the Northwest, if I put obesity as a top line ICD-10 code in my chart, it get kicked out because many of the payers, many of those who govern us say, we don't treat obesity medicine. Wow, you mean we don't treat something that's affecting 50% of the population? That's an amazing public health crisis we're dealing with. And so start that conversation. Meet the patient where they're at. Make it a lifetime of conversation and all the different facets, because we're really cheering those individuals on. And imagine if we all had a voice for ourselves and for others in our workplace, in our health place, we would be able to tackle this and to turn this thing around.
Yeah.
George, not only that, George, but there's a question that somebody asked is what does the employers play, or how does the employer play a role in this? And part of that is we should see each other as clinicians. We should see ourselves as partners with the employers to say, we need your help. For example, there's employers in my area, as I was telling Dr. Miller, HEB, for example, is a big employer in Texas, has over 150,000 employees. You know what? They pay for obesity medicines. They say, look, this is important. We have this, they actually send me patients for that. And because what they do is they say, we want this employee to be with us the next 25 years. And we know that bypasses cost X amount of money. And we know that diabetes costs X amount of money. We want to prevent this sort of thing. So how does the employer play a role? We should be partners where we say, hey, let's work together with this to try to address this. recognize it as a disease, just like you would any other disease, and address those things.
Yeah, thank you for making that point, because some employers are covering it, some are not, and we're gonna get into it in just a second as to what the treatments actually are, and then we're gonna move to that. Employers now hopefully are seeing more than half of their employee population, their workforce, is dealing with obesity, and it's you get to blame to biology. Half of your workforce. You cannot blame half of your workforce. There is something biologically going on. So we've got to flip that switch somehow. So let's talk about the treatments that a person with obesity should be afforded, should be given. It starts with lifestyle management. So what does that really look like?
And certainly, when we send patients to dietitians to look at weight, to get them motivated for diet, and we tell them, look, that's important. There's no question about it. The question is, how do patients maintain their diet? And we talked about the biology of this hormonal conspiracy of your brain trying to get you back to that weight that it thinks is a normal weight. So diet and exercise cannot be the sole thing. We often look at patients and say, look, you need to do more diet and more exercise. That's a component about it. Then I think that, in my opinion, I think it's a small component of it. But the other issue is how to motivate people to do this. We talk about, when you look at facilitating behavioral changes in patients, there's two major things we need to look at. Number one, what motivates them? Sometimes Dr. Miller and I will have patients say, well, I got to get ready for a wedding, or I'm going to my 25th high school reunion. That's a motivation, yes. So how do we motivate them? Tell me what's important to you. And then we use these motivational interviewing skills to get them to do. But the other thing is, how do we give them confidence that they can do that? And that's where I think a lot of these medicines that we have available for us, it gives them the confidence that they can lose this weight and allow them to stay on a diet and exercise program there. And part of this intensive behavioral therapy, just like it says here, smoking cessation, most of the time, look at the last part of the slide. It says 97% of dieters regain everything they lost and more within 3 years. Why is that? Is it because they're lazy? Is it because they choose to do it that way? No, because the biology is telling them we got to get back to that weight.
Yeah,
and that's where we need the help. And that's why, when the participant asked, how do employers play a role here? I said, man, I have this toolbox that I want to use, and I know the tools in this toolbox are going to help, but I can't use them because they're not available for the patient.
We're locking the tools kit up. Yeah, I just want to underscore for the audience a bit about, how many of the HR teams out there will cover as many smoking cessation courses as the person will go through. And we won't even cover intensive behavioral therapy or nutritional counseling for obesity. This is they need help. And so this is not expensive, guys. This is very inexpensive from a healthcare spectrum. And we've got to give them those tools, because I know as we get to the next slide, we're going to talk about the medications. The medications, I believe you're going to tell me, work better if the patient's also doing diet and exercise, right? So let's get into these medications and share, Dr. Miller, a little bit about what these are, how they work from your perspective. Are they working for your patients?
Oh, absolutely. I'll tell you, it's a good day in metabolistic medicine. And as Carlos was saying, I think one of the hardest things in having this as a focus of our practice is we know so much out there that we could do for an individual. And to really kind of give you a top down, there are indicated drugs that have been approved by the FDA for individuals who have what we call comorbidities or other things with a BMI of 27 and above. And those who don't have those comorbidities, which, many of them do, 30 and above are in the actual obese category. But these are actually hormonal related drugs. You know how we talked about the hormonal conspiracy? We're treating them with hormonally mediated drugs. And these are gut derived neuroendocrine hormones that we're discovering in Singularity, in Dual, and Carlos and I sat together and learned about the new 3G coming out, just all these things, and they're all hormone related. And it's not so much the particular brand, but it is therapies that are that are going above this massive metabolic drive. And they're doing it in a way that, you know, I hate to use the word loosely, naturally, they're doing it in alignment with the biology, but it's multiple factors. Metabolism is three-dimensional. It's not one-dimensional. It's not just diet and exercise. It's diet and exercise, it's timing, it's therapies, it's hormone, it's mind, body, spirit. And that's great because there's lots of ways to intervene. And we see significant, you know, that it talks about GLP-1 therapy at 15%. We have other dual incretins that are approaching 20%. And we have even things on the horizon that are not even available yet that are approaching 20 to 25%, which just blow our minds. And so it's a new day for intervention. It's very optimistic.
And it is exciting. And you think about where this can go. And I want to underscore for just from a lay perspective, these drugs are hormone replacements. These are hormones that we're giving the patient. That's what's happening here. It's a hormonal imbalance. And you know, again, back from blame to biology, there's something going on, and we're helping to fix the biology of it. And by the way, the fix works.
It does.
Works, and that's what's so exciting.
And I think the common question is who qualifies for these medications? As you can see, anti-obesity medications, we usually start with a BMI of 27 and some comorbidity. If they have, you know, if they have diabetes, if they have high blood pressure, they have high cholesterol, they have pre-diabetes, they have sleep apnea, they have depression. That's another thing. That's a comorbidity. But once you hit a BMI of 30, then you can use these medicines. They should be available to us.
And there's a question in here, which I don't think I know the answer to, but does studies show food contamination in terms of what regulation allows? Pesticides and additives, are they playing a role in the increased obesity? I don't know that we know that. Do you?
We don't know definitively, but I will tell you, and we both know that they are looking at all of the contents of nutrition, the gut biome. We just had a recent update in the causes of diabetes, and I was involved in that, of the contributors of inflammatory markers and gut microbiome. It's not a singularity. We don't want to land on one particular thing because we're a cadre. There's even been some recent discussion of high fructose corn syrup and gene activation. I think as we're drilling down to the metabolism and the biology, we're getting little tiny nuggets. And what I would really caution many of us is to look at it at the whole, not a singularity. The body is not so simple as to say it's one particular thing, but to acknowledge the genetic, the environmental influences, absolutely, because there will be interventional opportunities.
And
I'm glad the participant asked that question, because, you know, there's a term for that. They're called endocrine disruptors. And you're right, it's a complex. We're talking about, we're doing a sort of a 30,000 foot overview on this, right. But these can be endocrine disruptors that can affect that, no question about it.
And I think I shared with the audience, these two are experts, and they can geek out on whatever terms you want as we go into this. There was a question out there, just to, you know, these medications need to be taken for life. It's a hormone supplement. And
the reason for that, George, you know, we don't today in 2023, we don't know how to readjust that thermostat. That's what I tell the patients. You know, if your body thinks that let's just take a number like 250 pounds is your normal weight. How do we readjust that thermostat to say, no, it's really 150? We don't know how to do that. So until we learn how to do that, and a lot of research in obesity medicine to look at that. But until we learn how to do that, yes, you're going to be having to take this medicine. Otherwise, you're going to regain that weight.
Okay. Yeah. And it's you know, we take blood pressure medicine for life. You take statins for life. This is just one of those, you know, maintenance drugs that unfortunately that you need. But the health benefit that comes from it is remarkable. So let's talk about the treatment of last resort, bariatric surgery. Let's talk a little bit about the benefits of that and how that works.
You know, both Carlos and I can have brief comments on this. We do make recommendations. There is a screening process or a preparedness for it. We want to make sure that you know that surgical intervention is once you have failed what we call the lifestyle, medication, and specialty intervention. And I hate to use the word failure, but maybe have not achieved the desired effects. These are done from the standpoint of health benefits, not to look good, per se, but to reduce some of the significant mortality and morbidity associated with those individuals. And so there are particular criteria and thresholds based on BMI and what have you. It also is not something you enter in lightly, because having that surgical change, which is an amazing rewiring of the biology, it really is fascinating how these metabolic effects happen immediately. They're not once the weight occurs, it's overnight. And it's all fascinating as physiologists to talk to the surgeons who just say, oh, it just happens. And we say, why, to unpack it. But there is a preparedness for it, because you have to have behavior and be willing to support that change in your biology.
Yeah.
And not only that, but even, and just like I do what you do too, I often, when I refer a patient to bariatric surgery, I often tell them, you need to come back to see me, because the majority of people with bariatric surgery are going to gain weight again. And even with surgery, they will. There's a tremendous drive for you to get back to that maximum weight we call the set point. So often we'll say, we're going to send you to a surgeon to refix your plumbing or to redo your plumbing, but you got to come back to me, because we're got to probably start you on some of these medicine to prevent you from gaining weight again.
Yes.
And gaining it all back.
Yep.
Well, guys, I really appreciate you sharing all this. We're running just a tight time here, but thank you so very much for sharing your expertise today and with this group. It's been a pleasure, and it's a fascinating topic. I look forward to continuing this dialogue as time goes on, as we go. So again, thank you so very much.
Thank you.
Thanks, George.
I'm going to move us to a new poll question. Does your plan, now that we had this conversation, does your plan cover anti-obesity drugs? Is this something that is currently covered by your plan? I think somebody had in their chat that they were on this with a very favorable, result, but it wasn't covered. We're fine. It's a new class. And one of the things that it's not covered by Medicare yet. And in fact, when Medicare Part D was put into place back in 2006, in the law, it says that Medicare coverage cannot be used for weight loss. And back in 2006, none of these drugs existed. The only thing that was out there was fen-phen, which was effectively speed and was causing heart attacks, et cetera. So Congress, in their infinite wisdom, did not see that there could ever be something moving forward, and they locked it. Patient advocates are working to unlock that, but I'm curious as to whether anybody's covering this today. Many employers, some are, and some are not. We'll see how the audience lets us know, and some may not know. Okay, so 10% are covering, which is about what we're seeing in other groups. 41% are not covering it, and about half don't actually know. And that actually, I'm not surprised by. 49%, half the audience did not know. So thank you for your cooperation on that and sending it in. I'm now going to change the dialogue from the blame to biology. We're going to go back to the blame and talk about the stigma and the bias and discrimination that comes in here. So I'm going to invite Dr. Rebecca Pearl. Thank you for joining us. Dr. Rebecca Pearl is an assistant professor in the Department of Clinical and Health Psychology and in Social and Behavioral Sciences at the University of Florida's College of Public Health and Health Professions. That's a mouthful. She directs the Body Image and Stigma Lab, which conducts research on health and appearance-related stigma. So, Dr. Pearl, thank you so much for being with us today. Stigma, as we know, is a powerful thing. A sizable portion of our country, hopefully not this audience, believe that obesity is the patient's fault. Let's talk to us about how damaging this can be. Give us a little bit of background.
Yeah, well, thanks for having me and for incorporating this important topic into this conversation. I think most people have heard the terms fat shaming or body shaming, and this is really what we're talking about when we think about weight bias and stigma. And so these negative attitudes about people because of their weight are often rooted in the very common misconception that weight is entirely within an individual's control. And so if we think that way, if we think that people can just snap their fingers and change their weight, then that leads to this blame, this, sense of it's their fault. There's a moral judgment that can be attached to that. And we also know there are lots of assumptions that people will make about a person's internal characteristics based on their external characteristics. So just looking at someone based on their weight, people might assume that they are less intelligent, that they're lazy, that they have less willpower. And of course, we know that people's appearance and their weight have nothing to do with their personality characteristics, their abilities, their competencies. But we know that people do tend to make those kinds of snap judgments. And altogether, that blame and these negative stereotypes and biases can lead people to be discriminated against, socially rejected, teased, bullied, or overall treated unfairly. And that's really what we're talking about with stigma.
Yeah, and and we see it everywhere, and it's rampant. So thank you for explaining that. Now we know that it can manifest and deeply rooted in our society. Where does it show up?
Well, unfortunately, it shows up all over, as you've said. So we can think about the different levels at which this stigma can occur. So at the broadest structural or societal level, we can think about laws and policies that perpetuate weight stigma or that don't protect against it. So for example, it is legal to openly discriminate against people because of their weight in most places in the US and around the world. We also see this in policies within institutions of not having protections against weight discrimination. We've talked a little bit about some of the insurance policies that may discriminate against, weight-related or obesity treatment. We of course see this in media portrayals all the time, in newspaper articles about weight, in movies and television shows where the characters with a high weight are kind of the butt of the joke or portrayed in a negative light. And then we also have person-to-person examples of this, of people being teased or bullied because of their weight, discriminated against, having negative healthcare interactions related to weight. And then the last level occurs within individuals with a high weight. So this occurs when people are aware of the societal stigma and start to buy into those negative stereotypes and maybe even apply them to themselves. So that's what we call internalized or self-stigma.
Yeah, and that can lead to real stress. Psychological stress can lead to real health outcomes. So talk to us a little bit how they can impact a patient's overall health.
Yeah, so unfortunately, weight stigma does have really tremendous health implications in a number of different ways. So I do want to first say that any form of discrimination, including weight discrimination, affects what we call social determinants of health. So these are things like the kinds of neighborhoods that people can live in, their access to health insurance, their financial resources, their social ties. So when people are denied employment or denied promotions or unfairly fired because of their weight, that can affect all these other kinds of social and environmental factors that we know ultimately will impair someone's health. Then there are also more direct consequences of experiencing or internalizing weight stigma related to mental health, quality of life, social relationships. We know that people who experience or internalize weight stigma are more likely to have depression, anxiety, as well as disordered eating or eating disorders. And then, as you said a moment ago, this is a form of stress, right? So you can imagine the experience, or maybe some of you have had an experience, maybe not related to weight, but some other kind of experience of being bullied or being criticized, or walking into a room and just worrying about what other people are going to think about you or how other people are going to treat you. That's a form of chronic stress. And there are really subtle ways where this can affect people on a daily basis of every interaction they can have. And so that chronic stress leads to coping behaviors that can undermine health. For example, it's very common for people to eat when they feel stressed. And so that actually has, a real impact and implications for obesity and for weight. If someone is experiencing weight stigma and eating to cope with that, that of course is going to exacerbate weight-related health issues, and also increases risk for diseases like cardiometabolic diseases, including diabetes and health or heart disease.
Yeah, I will just add a personal story on here as a patient living with type 1 diabetes. You say, can stress manifest itself in a physical way? My blood sugar will rise simply by being under stress. just, work stress, or perhaps because I'm, leading a program like this, and my blood sugar will go up because you have to be on. It will raise your blood. You haven't eaten anything. I haven't done anything. It just, your blood sugar will rise. Stress is real, folks, and it has a real clinical impact on people, a physical impact on people. So thank you for pointing that out.
Yeah, and that's a really great point that you bring up, because sometimes with weight stigma, people worry about removing stigma from obesity or weight because they're concerned that if people weren't stigmatized, or if there maybe just needs to be a little bit of stigma in order to motivate people to engage in healthy behaviors or to lose weight. But as you just pointed out, and there is research to support this too, that the stigma actually has the opposite effect, that it leads to behaviors like avoiding exercise or eating more, or even without the behaviors, there's research showing that things like blood sugar, blood pressure, those things are affected by these experiences of weight stigma. So stigma definitely has a negative impact on health. I hope if there's anything anyone takes away from this part, it's that stigma does not motivate people to be healthy. It actually creates worse health.
Blaming the patient doesn't help, and in fact, it's detrimental.
Absolutely.
So let's talk some examples of workplace bias in particular for this particular audience.
Yep. So there has been a fair amount of research about what folks will call a wage penalty related to weight. And this particularly affects women and people at the highest end of that BMI spectrum that you saw earlier. So we know that there is a wage disparity in these studies when economists control for lots of other variables that can affect these sorts of outcomes. Weight still comes out as something that is predicting lower wages, which the researchers really can only attribute to discrimination. It's not other kinds of health factors or other, some correlated kinds of factors that are explaining it. We know that people may be less likely to be hired for positions, that they are, possibly going to be unfairly fired, denied promotions, or overlooked for promotions, even when qualifications are the same compared to leaner individuals. And, as I mentioned earlier, some of this might be driven by some of these maybe even unconscious biases of assuming that people might have different capabilities or might not be working as hard simply because of their body weight.
We all see it happen. Hopefully we can, raise our own awareness. So let's talk about, how can they actually reduce the stigma and bias, and what can this group take back away to help improve this situation?
Yeah, well, there are a couple of ways to start. And so there might be ways, for example, of implementing procedures that try to remove the bias from hiring or firing or promotion decisions. So one example would be in hiring to remove photographs, or to not request or require photographs to accompany job applications, so that a person's appearance and their weight will not be influencing any of those sorts of decisions. To use standardized rubrics or ratings for employee performance that, again, removes appearance, from those evaluations. And then other kinds of things that can help promote an environment that's more inclusive. So there has been increased attention to diversity and equity and inclusion kinds of efforts, but often weight is not included in those discussions or in those trainings. So kind of shifting the thinking of body weight and size and shape as forms of diversity that need to be included in those conversations in order to understand and have more sensitivity toward people in different bodies. So I think, also having no tolerance for any sort of bullying, discrimination, negative commentary, even things that might seem innocuous, like a joke about someone's weight, or even in the break room talking about, one's own weight and, oh my gosh, I shouldn't be eating this, I look like a pig. Like those kinds of comments can really be uncomfortable and insulting and offensive to people in larger bodies.
Yeah, and it's one of those where even if you're doing it as self-deprecating humor, because you're one of those, because it's half of the we talk about this discrimination and diversity training for the minority populations. This is half of the workforce. So, it's not the minority. It's half the workforce or more, depending upon the company that you're dealing with. But the patient that is the person, the employee that is even using it as self-deprecating humor, and we've all one, they're harming themselves, but they're perpetuating the problem. So I like the first thing that starts at the top: identify your own potential biases. Start within. Think about how you are doing it. Are there times where you are engaging in this? And if you can do that as an HR person, that's how you can help coach the rest of, because to me, the HR team, I've always viewed them as the coaches. You're there to coach the rest of the folks on how to manage, how to handle situations that are delicate, that are difficult, etc. This is an area where HR needs to lead. HR needs to step up and lead. And step one is understand you need to do it. Understand we've got an issue here, and an employer can play a role. And the HR, yeah.
And, everyone has biases. So just, having these automatic associations or biases does not make someone a bad person, but it's being able to acknowledge that and then make sure that those biases are not translating into behaviors that are harming others.
Yeah, exactly. So let's shift over to workplace wellness. Now, these initiatives are really popular. They're among both employees and employers, love it, but they can also have unintended consequences if poorly designed. Share a little bit about that.
Yeah, so these can be really beneficial if implemented thoughtfully. And one of the main recommendations is to focus these initiatives on improving behaviors, not necessarily focusing on weight itself, because people can't just change their weight. They can't just decide to do that. They can change their eating habits, they can change their physical activity habits, and that might result in changes in weight. But we want to reward behavioral accomplishments and achievements rather than focusing so much on the weight itself, because sometimes people can, use very extreme methods to change their weight that are not healthy. So that's not actually achieving wellness. But if we're rewarding the weight and achieving that weight by any means, then that may actually be rewarding unhealthy behaviors.
Yeah, and that's really important, because you'll give out pedometers in the lunchroom and t-shirts and all of that, but you've got to aim it at something, keeping the workplace culture healthy and encouraging those behaviors. And I love the ideas, make your stairwells safe if you can. If you're in a building where you've got a second or third floor, encourage people to take those steps. It's healthy. The employee of the month should not get the parking spot by the front door. They should get the parking spot by the back, so they actually get a longer walk in. That should be the reward, so that you can actually do those healthy behaviors. All that everybody should agree to park in the back of the parking lot, as far away from the building as we can. Just do it, those little things as you can go through it. Smoking cessation is a great idea always, but nutritional counseling, helping them have those things that are going to help them live a healthier life. So. Yeah, thank you so very much for sharing this. I know we're at the end of our hour at this point, and I'm so appreciative for your expertise and getting this dialogue to this stage. So again, thank you for being with us. We've answered a lot of things in the Q&A as we have gone, and we are literally with about a minute or 2 minutes left. I hope that the audience has gotten some good takeaways from this. I've seen a lot of dialogue on how expensive some of these anti-obesity medications are, and hopefully over time those costs go down. As a patient advocate, I do hope that these costs go down. I do hope that as employers begin, this gets to be a supply demand as a finance person. As employers start covering it, some employers will have some more leverage on these things. I'm not here to negotiate these things, but the societal impact of having access to these medications is going to be enormous as we go, and I'm excited by where this could be. So I hope that you all have enjoyed this presentation and gotten something from it. The slides should be available through hr.com. We have materials on our website at diabetesleadership.org under Employer Solutions. We have a number of health plan design issues that we get into and ideas. Please, reach out to us if you have any questions or want to have a particular dialogue. Again, thank you so much for spending your afternoon with us. I hope you found it valuable.
Thank you. Thank you so much, George, and to all of your presenters. Just such excellent information. For those of you who happen to have come late or would like to view it again, it has been recorded just now and will be archived shortly on hr.com, so you can view it again at any time. And for those of you looking for HRCI and SHRM credits, those will appear in your hr.com account, as always, within 2 business days if you have attended the complete session. And we'll also send you an email with your credit information. And most importantly, I feel your feedback is so important to us and all of the folks presenting. So just take a moment. When I close out this session, a new browser will open with a short exit survey. So just take the time to fill that out. And I hope that everyone has a great remainder of your day. Take care, everyone.
Thank you.